My name is Ted Meyerson. I'm a volunteer with AARP Maryland. For the last 12 years, the day after Tax Day has been designated National Healthcare Decisions Day. Because of the COVID-19 pandemic, Tax Day was moved to July 15th, and National Healthcare Decisions Day moved with it. That's why this year, National Healthcare Decisions Day is July 16. The mission of the National Healthcare Decisions Day is to educate the public and healthcare providers about the importance of advanced care planning, to encourage everyone to express their wishes regarding healthcare, and to help ensure that providers and facilities respect those wishes. Most people feel they won't get sick in the foreseeable future and don't want to talk about what would happen if they did. So they never get around to making long-term healthcare plans. But this year might be when we all want to do some planning. Millions of Americans have gotten the coronavirus, and over 135,000 have died from it. Sadly, one thing seems certain: there will be more infections and more deaths, and there is no way of predicting who will get infected. It might be you, it might be me, anyone. That is why everyone should make plans to ensure they get the treatments they want, and they don't get treatments they don't want if the worst should happen. Today, we have a panel of experts who are exceptionally qualified to fulfill the mission of the day. Dan Morheim is a practicing emergency medicine physician, was a member of the Maryland House of Delegates from 1995 to 2019, and is an author whose newest book, Preparing for Better End, will be released this fall. Amy Tucci is president and CEO of the Hospice Foundation of America, which recently completed 2 national outreach projects involving advanced care planning. One involved Being Mortal, a PBS Frontline documentary, and the other was the Hello Project, which used the conversation game Hello to engage underserved populations in conversations around end-of-life care. Gene Ransom is the executive director of the Maryland State Medical Society, MedChi. MedChi is the statewide professional association for licensed medical practitioners, whose mission is to serve as Maryland's foremost advocate and resource for physicians, their patients, and the public. Each brings a different perspective to advanced care planning. AARP, the State Advisory Council on Quality Care at the End of Life, and the Horizon Foundation are honored to have them as guests. You know, I want to start this with a short story. A couple of years ago, I slipped on some ice, banged the back of my head. It was cut open. My wife insisted, I felt fine, but my wife insisted I go to a medical center. The doc there said, well, you really need to have this stitched up, and we really need to do a scan. And I said, well, okay for the stitching, but I'm not interested in a scan. So he stitched me up and I went home. Well, if I'm able to make those decisions, why do I have to make any plans in advance? Gene, what's that all about?
Well, first of all, Ted, thanks for having me, and I really appreciate the work that AARP has done on this important issue. I think one of the really important things is that people should think about this, and it's something we don't like thinking about, but end of life and making sure that your choices are honored, obviously, is something that's really important and something that I know is important to AARP. So in your example, you were cognizant and had the ability to make a decision. So the reason you need to think about this ahead of time, and Dr. Morheim, as an emergency room doctor, probably has countless real life examples of this, is that when you roll in after a car accident or after an incident, you might not be conscious. You might not be able to make a decision. And that means you're essentially leaving the decision to someone else. You're leaving it to a health professional, possibly, or to family members and others, and you've taken the decision out of your hands. So it really makes a lot of sense to think about a couple of these key documents, an advanced directive, other most forms like that are really important for you to take the time to fill out and have them there. So when you end up in the emergency room, what you want to have happen with regards to your healthcare is your choice, because many times you're not going to have a decision to make like you did have a decision to make. So the power is with you. It's just a matter of making sure that you're able to communicate it.
I know these are challenging topics, and there's a lot of reticence in the general public to talk about it. But really, this is about empowerment and respect for your values. And we're the first generation in human history that likely has some say about how we die, but also about how care is managed in general. And it goes beyond, Ted, the decisions that you would make, because a head injury could also, it doesn't mean at the moment you just appear to have a laceration, but a few hours or a few days later, you could have a more serious internal problem. We don't go into your medical history here on this call, but are you taking a blood thinner, an aspirin, or something else? And that could cloud your consciousness and make your decision making more difficult. But it's also, as a clinician, who do I speak to if I can't communicate with you? Is it your spouse, your adult children, a friend? These are all really important things. Who do I transmit information to? How do I get in touch, in fact, with your own doctor and other medical history in the background? I recommend that people put together a little medical go bag that has who not only should they complete an advanced directive and that have to be the main part of it, but list their family contacts, the medicines they take, prior lab tests, a recent electrocardiogram. All of these are readily available. Staple it together. This is what mine looks like. But and if you go to the emergency room, hand it to the staff. I can't even begin to tell you how much time emergency department staff, nurses, doctors, social workers, pharmacists, physician assistants, we're all spending a lot of time scrounging for information to take better care of the patient. So in your situation, who knows what might have transpired in an hour or two? Fortunately, you did fine. But if something could change, what were your decisions? And equally importantly, who do we contact to help manage your care?
Amy, what do you see when that happens?
Well,
When somebody comes in with no information.
yeah, I think what happens, well, that doesn't happen very often with hospice care, because usually there's a process that involves being admitted to hospice, which just a 30-second description of hospice. It's not a place, it's a service, and it's for people who are terminally ill. In the case of COVID-19, hospice is actually taking care of many patients who have been on respirators, who have made it clear that they don't want to be on a respirator, and their family knows that. They have an advanced care plan, perhaps. But the most important thing is that their family knows. Their family, the people, their loved ones around them know what they want at the end of life. If they don't want to be kept alive by artificial means, that is something that's just so important. It alleviates a huge burden for family members who may struggle with making those decisions. And in the case of COVID-19, isolated in making those decisions because you can't get into the hospital to be by the bedside.
Well, Dan, what happens if somebody is on a ventilator, is deemed to be terminal, and has no instructions? What do you do?
Well, it's always a problem. And the whole point of National Healthcare Decisions Day is that people aren't in that situation. It turns out that only about 40% of Americans have completed advanced directives, and it's about half that in the minority population. In fact, we identified it as a minority health disparity in the American Journal of Public Health. In the end, we'll always make decisions. It just may not be the decisions that the person would have wanted. There are hospital committees, patient care committees, or ethics committees that we can go to. We will involve all sorts of other people. But in the end, what I really want to do as a clinician is respect the patient's rights and autonomy. And this is all about empowerment and values. And having, in a culture, in our culture, which seems to value individual autonomy so much, it's odd and inconsistent that we collectively don't complete these free, legal, straightforward forms that anybody can do anytime from any number of sources online like mydirectives.com or from the state attorney general's office, any office. I did want to say one thing about hospice, because in the book that I wrote, Preparing for Better End, which will be out this fall, the chapter on hospice starts off. The first thing I hear about hospice is, I wish I'd called hospice sooner.
Absolutely. We hear that all the time, Dan.
The number one thing, hospice is a great service. Members of my family have appreciated the hospice service and palliative care, which is too often relegated to kind of the end of things instead of at the beginning. I will tell you this, if I got a bad diagnosis today, even if I thought I was going to live for years, I would still contact a hospice today to plan ahead for that. I'm sure Amy knows the exact statistics. Average length of stay in hospice is maybe 20 days?
It's far too short.
We've all paid for 6 months of service. So from an economic point of view in our taxes, you can be in hospice for 6 months, but we're only using 20 days. Why not take advantage of this wonderful service? Caring, sensitive, and we just don't do that. So there are other things here that can be done both on the acute and in the non-acute phases.
Well,
Totally. Thank you for that, because you've made a great point. There are 4,000 hospice providers in the United States, some unbelievable hospice providers in Maryland itself, and they are all Medicare certified, these 4,000 hospices, and they will provide care for months and months. It's not limited to 6 months of care. It could be a year and a half of care, as long as somebody is still declining in health. It's still available to them.
what do you do in hospice? What kind of services? I mean, you say hospice. I don't know what I get from hospice.
Okay, so hospice involves a team approach to care, and that team consists of a medical director, a nurse, a registered nurse, a certified nursing assistant, a social worker, a chaplain if you want it, and it can also involve a variety of other healthcare professionals and volunteer services like massage therapy and beneficial things like that, aromatherapy, music therapy. And it's all designed to make the most out of someone's remaining days. So it's not like you need to be bedridden to receive hospice. You can be moving around. You can be enjoying life. You can be enjoying time with your family. And that's really what hospice strives for, to control pain, to control symptoms, and to make life worth living. Instead of being, in a hospital environment, perhaps. Though hospice can be delivered in a hospital, but the overwhelming majority of hospice care is delivered wherever a patient lives. So that could be a nursing home, it could be assisted living, it could be a person's home itself.
All right, just one quick question, and then I want to ask a question about advanced directives. But before we leave hospice, if I were to be qualified for hospice and I'm at home and my wife can't shop or whatever, can she get help?
She can get help from a volunteer. That hospice, all Medicare certified hospices provide volunteer services. A volunteer can come to your house. Your wife can get out and go shopping, get her hair done. Well, maybe not now, but you can rely on those hospice services as much as you need.
Dan, you mentioned an advanced directive. What is that, and how do you do one?
Well, first, let me say that thank Gene Ransom very, very much in our Maryland State Medical Society, which I'm a member, for promoting not only this event, but a whole range of educational issues for clinicians about advanced directives. An advanced directive is a free legal form. They've been around since 1990. They're legal in every state. It's really 3 parts. Part 1 is, and it's filled out by the individual. It's not filled out for you. Each person takes responsibility for their own advanced directive form. And there's 3 parts to it. First part is, and it only goes, as Gene and others have mentioned, it only goes into effect when you can't make decisions for yourself. If you're awake, alert, and competent, your advanced directive is a document on the side. It comes into play when you can't make decisions for yourself, which could be before surgery, an illness or disease that affects your ability to decide things, like dementia might be one, but there are others. 3 parts. First part, how much care do I want? And there's kind of 3 choices there. Do I want the full court press, or At the other extreme, pull the plug, or what most of us choose is the middle path. Keep me going as long as I'm functioning, awake, alert, enjoying life, doing the things that I enjoy, and I'm pain free. In fact, if you ask people in general, and I do this when I do presentations, where would you like to be in the last hours and minutes of your life? 5-second exercise. Everybody says almost the same thing. I want to be at home with my family and friends around me. Now, if I get chest pain or in a car accident, please take me to the emergency room and give me all the care. But I don't want to die in a hospital after stage 4 pancreatic cancer tied to tubes and machines and some horrible septic shock death long past hope of recovery. So part 1 is sort of the outlines of what kind of care you want. And I think it's for every adult, not just seniors. The 3 most famous cases in American legal history are women under 30. And so when you're 18, I think you should complete an advance directive. But what you do when you're 18, 28, 58, and 88 will be different. Part 2 of the advance directive is who will make decisions for me if I can't. And that's someone you trust, typically a spouse, but it could be an adult child. I could pick Jean or Amy or you, Ted, to be my healthcare agent. I would have a conversation with you about my wishes, but you can pick anybody you want. And step 3 has to do with other factors: body disposition, organ donation, which I'm strongly in favor of, burial, funeral. But in there also, you can put other things. I really want to make sure I get hospice care. I want to make sure I get early palliative care. I want to have in mind, for example, that I want to be taken outdoors as much as possible. I want control of the remote. That's important to me. So when the TV's on, I want to control it. And by the way, you can put things in there like this. I don't know if anybody has an annoying relative in their family, but you can say, please leave Cousin Fred out of the discussions when my health care is being discussed. You may have an annoying relative that comes in and takes over the conversation. Mine also says, while my family members in a certain order can make decisions, I want them to also talk to my best friend from medical school. Not that that person will be decision making, but I value and respect his opinion. We've been friends for a long time. So you can do all kinds of things with an advance directive and some of the attachments. You can also do a video on some of the online ones and leave a message for your kids or grandkids or your friends and family that you want to say something about your life and perspective on it. So it's a fluid form. You can update it anytime. And the last one you complete is the one that's the legal one, and that's operative. So that's basically an advance directive. You can get them everywhere.
Gene,
One of the suggestions I would make, if you're in Maryland, is there's a guide. It's an 18-page guide the Attorney General has, and it's really good. It gives you everything you need to know. It answers questions. It has frequently asked questions in it, but it also has a legal form in it that you can use and follow and help you fill it out. And if that's something that you haven't done, I'd say this is a good first step in trying to get an advance directive and move forward if you're in the state of Maryland. But I'm sorry, Ted, you were about to ask me a question.
What do docs think generally about it? Are they willing to take the time with a patient to talk about what choices might be?
Yeah, the answer is definitely yes. And I'd say more so now than it used to be. I've worked for MedKai now for 24 years, and this issue rarely came up when I first started working there, but now it does all the time. And one of the things that's happened is the insurance companies and CMS, which is the entity that bills Medicare and Medicaid, now pays for physicians to have a discussion with their patients about end of life. So because the physicians can be compensated or reimbursed for their time talking to the patients about it, no patient should ever feel bad about talking to their doctor about this. In fact, I think having a discussion with whoever your primary care practitioner is about this issue is a really good first step, just to have a discussion about it, because a lot of folks don't know or don't think about or don't know what it's like when they go and seek healthcare help, where these practitioners will be able to say, hey, this is what to expect, here's what's going to happen, do you have any questions about what might or might not happen to you or fears you might have? It's the appropriate place to have that discussion. And remember, you don't have to feel bad about it. You don't have to feel rushed about it, because the practitioner is now going to be compensated for having that discussion with you. So they should never feel uncomfortable or feel bad about having a discussion with their doctor, their physician, about these types of issues.
Let me just pick up on
Go ahead.
if I can. Gene is exactly right on all of that. The form, though, ultimately in an advance directive, as opposed to some other forms, first has to be completed by the patient. Secondly, it needs to be made available. This should not be put in a safety deposit box. The advance directive needs to be shared with your physician, maybe your attorney, maybe your religious advisor, certainly the hospital where you're most likely to go. But it also can be portable. You may be traveling in other states. Some of them are able to be shrunk down to a QR code or a barcode or something on your cell phone, because we never know what's going to happen to any of us. So step one is complete it. Step two is make sure it's available, not hidden away. And then when it does come to clinicians, more and more clinicians, thanks to efforts of MedChi and others, the State Advisory Council on End-of-Life Care, then we need to learn to honor them better. We just don't see them often enough. And so we will honor them when we get more familiar with them, but it's not quite as normative as it ought to be.
Well, I've got two questions. One, Amy, do you have any experience about how much it costs to make an advance directive?
It costs nothing to make an advance directive. It's not, there's no fee associated with an advance directive. So, like Dan and Jean say, everyone should be making an advance directive. But I think one thing we're kind of missing is that sometimes people, the numbers show it, people are reluctant to make an advance directive. So maybe a first step for a lot of people ought to be having that conversation with their family and loved ones around the dinner table. A lot of people pick Thanksgiving to do this, actually, just to sit down and say, hey, what's important to you? If this happened to you, what would you want us to do? What kind of decision would you want us to do? It admittedly, it can make people important. The one thing we found at Hospice Foundation of America when we partnered with Penn State to do this project called the Hello Project, which uses a very innovative game to get people to talk about their end-of-life wishes. The game it's sort of a card game that has questions that are both heavy and light. Things like, what's the, what kind of music do you want played at your funeral? That can get you into talking about other things that are important to you, other values that are important to you. Because when the time comes and you are in an emergency situation, a physician, a hospital may not be able to get that advance directive that you've so, carefully filled out, unfortunately, which is not I don't want to minimize the importance of advance directives at all. I think they're incredibly important, and I wish people had to complete them to get their driver's license. But the very important thing is that your loved ones know what you want as well. So if there is that situation where the doctor can't put his or her hands on your advance directive, somebody else can speak for you.
Well, should I keep it in my safe deposit box?
Oh, Lord, no. Absolutely not, because nobody's going to know where that is or know how to get into it. And that can be a problem actually with cell phones too. It's like, how do you get past that screen that if you don't know the passcode? So there are innovative things going on in the country. There are some innovative things going on in Maryland with the Speakeasy project, where there are electronic forms that you fill out, your advance directive, and physicians have access to those. Many states are working to pull these resources together. So, no matter where you are, you'll be able to, as a physician, be able to get to an advance directive if it exists.
Well, suppose I don't want to do all that stuff, but I tell you what, I'll make a compromise. I'll assign somebody to be the person to speak for me. And I wonder, should I not have a backup person as well? And what would make that a legal document, Gene?
Well, again, if you filled out the appropriate, you don't have to use the state form, but you can use the state form. But if you filled out the state form, let's say, for example, because you don't want to spend any money and you want to make sure it's good, you've done that, you would designate them appropriately in those two places. And I would suggest, if you don't want to go through everything I would suggest you go through everything Amy just went through. First of all, she's absolutely right. But let's say you don't want to go through all that. I would suggest two things. First, give a copy of the advance directive to your primary care physician. Have them put it in your medical record, because that's very helpful. And the other thing I would suggest, if you're comfortable with it, is there are ways you can put it on upline. And in Maryland, we have a program now where it can be connected through the Health Information Exchange, which is run by CRISP. So if you get it in the medical record, either through your primary care provider or by uploading it, that would mean that it would be tied to your medical record, and that would be very helpful. The second thing I would suggest is take copies of that document and give it to the person who is your designee and to the alternate, and let them have a copy of it so they know, because assuming that that person is going to be someone who cares about you and will know if there's a bad outcome or something that happens, then they're going to have a copy of it and they can present it when it's appropriate. I think those are the easy, very simple things you can do. You're going to have a conversation with those designees anyway, and then that way they have it, and there's an opportunity to make sure that your wishes are actually honored when there's some type of bad event.
Let me emphasize, Ted, let me emphasize why it's important that this be written. I've been in many clinical situations in my 40 years in emergency medicine where it's not written and families get in conflict. There might be three siblings. One has one opinion, another has another opinion, the third has another opinion. I've seen families tear themselves up over this. But I've also seen situations where a person had made it clear in writing. And I, as a clinician, then know that I'm honoring that person's wishes, and it actually solves the problem for the family. Remember, when an advanced directive becomes operative, you're not making decisions for yourself. And so you're really taking care of your loved ones. You're making it easy for them to know what you want. And that's what's important. So yeah, you should have a conversation, but it's really important to have it documented so those family squabbles don't erupt, especially at a time when there's limited minutes to make important clinical decisions. So complete the form and get into the electronic health record, all the things that you have to do, and it's free. And there are barriers. I mean, people are reluctant to talk about this. I can sometimes think there's magical thinking. If I fill out this form about my dying, then I'm more likely to die. There's a certain amount of distrust of the medical system, especially among some of the minority populations that have been reluctant. I communicate with them. I'm pleased that my book was endorsed by, among others, the president of the physician president of the National Medical Association, the largest organization of African American physicians in the United States, because it's really about empowerment. It's one of the few things in healthcare where, for free paperwork, you can actually increase the likelihood of getting some of the kind of care the way you want and solve a lot of these problems for your family.
All right, let me ask you this question. I don't want to do any of that stuff, but I'm willing to assign somebody to speak for me and a substitute. And I take a piece of paper and I write that down. What do I have to do to make that legal?
You get it witnessed in Maryland. Most states, it's two witnesses. Some states require a notary. But we'll, as an ER doctor, we'll take whatever we can get. That's not ideal. That's a start, which you just outlined. But you know, Gene held up the paper. There are other from the state of Maryland Attorney General. They're really just a few sheets of paper. You take care, go through them 1, 2, 3. You're all done, and you get it all done. If you do a little bit, we'll take what you have. I mean, in a clinical setting, emergency room, we're always going to end up making decisions we need to make. We're not going to be paralyzed. We don't do that. We're going to act. But the best thing to do is if we act, knowing what the patient wanted, and we're dealing with the patient's appropriate designees.
One little caveat on that. If you're going to get it witnessed in Maryland, Dan's absolutely right. It's two people. One of them has to be someone who's not going to receive anything from your estate or anything from you afterwards. So that's an important thing to know and understand if you're doing it. So that's what we would suggest. There's no requirement to use any particular form, though. And one other point I wanted to make, just kind of adding on to what Dan said earlier, the physician actually not only really likes to see that document, they have to follow what the document says. They do not have the power to override it. And I think that's something that patients really need to understand, that once you've decided, if you've done it correctly and you've filled the forms out correctly, the doctor's going to have to do whatever you've asked them to do. within reason. Obviously, if something's medically ineffective, they don't have to do that. They have to meet the standard of care, but they have to do what you've asked them to do. So it's a really powerful weapon you have to make sure you get what you want when maybe you're not able to make those decisions.
Well, that's really scary because I could make one out today and they could get treatment for the virus tomorrow. And then what do? I've already said, let me go.
Yeah. I think, Ted, that's a great point. A friend of mine who's in his 80s called me. He said, I made my advance directive. It's all signed, sealed, delivered to everyone who needs it. But with COVID, I actually feel a little bit different about things. He lives in Florida. He thinks maybe he could be, with all of the cases rising down there, he thinks, things could get bad and he could be in danger. And he said, I would like to be treated. There are effective treatments now. I told him, I said, make sure you get that advance directive changed to have an exception for COVID if you feel that way. And make sure to talk to your wife, talk to your brother, talk to your son, make sure they understand it as well. There are exceptions that you may feel differently about what your advance directive previously had said.
There's no
How do I change it?
There's no form that's perfect that's going to solve every situation for every person every time. We've got 300 million people and a lot of different circumstances and clinical background. You can, as Amy correctly pointed out, you can put other kinds of things in there. You can, write free text of any number of details as long as you like into an advance directive. It's a fluid living form and you can change it. So there's always going to be situations where it doesn't work or it isn't immediately applicable, but it's much, much, much better for a whole host of reasons than having nothing.
So
That's what's important.
somebody told me that if I go online and make an advance directive, I don't even need witnesses. Is that right?
No, you do need witnesses, according to whatever your state is. And in Maryland, you need 2 witnesses, one of whom, of the witnesses, cannot be somebody who would benefit. I'd also think your physician cannot be a witness to the signature. But the healthcare agent can be your spouse who would benefit, presumably, if you died. So that's different. We're just talking about witnesses. But look, the more you follow the rules, the better it's going to be. But the rules are not hard. The forms are straightforward. They all have this built in, and nobody should be intimidated by the form. I just want to add one other thing, if I may, Ted.
Sure.
We're talking about the family and care and spiritual, but you can't talk about healthcare without talking about money. And this silver tsunami generation, of which at least 1 or 2 of us on this call are a member, Medicare is about $900 billion a year. About $300 billion is spent on end-of-life care. And if you reduce that by 5 or 10%, because most people are not going to choose, give me everything to the nth degree all the way, you save money. And that's been well proven in the town of La Crosse, Wisconsin, which made it their business to engage the health, business, and faith communities to achieve, instead of a 40% completion rate of advanced directive, a 98% completion rate of advanced directives. It's been better as an experience for families in the community. They also reduce their healthcare costs dramatically. And that's a much better way to do it, by respecting individual rights, than the typical things we do to reduce healthcare costs. Make it harder for providers to get paid, create an impossible bureaucracy for patients, shift burden to employers, raise deductibles and copays, all those other complicated things that make healthcare finances so complicated. If you complete advanced directives, you take advantage of hospice and palliative care, not only will you be getting better service and also shown living happier, more productive, better lives, you'll be doing it for less money. And that's a nice way to deal with that aspect of that issue, the finances of healthcare, rather than the bludgeonings that we all generally go through.
Dan, I was going to go around and ask people for a final statement. I'm going to take that as yours.
Okay.
Amy, would you have some final thoughts?
I think my final thoughts are that, we as a society rely on our medical system. We feel like it's a great system, which it is. And I think we have become so reliant on it in a way that we're we feel like people can live forever. That it's such a great system and it can keep people going. But we can't all go on forever, and everyone's going to die. That's the thing about the tax day and National Healthcare Decisions Day. It's going to affect all of us. We're all going to pay taxes, and we're all going to die. And it's so much better to be prepared. It's a gift that you can give your family. It's a gift that you can give society. As Dan pointed out, it's just such an important thing that everybody needs to do. And why we can't get our heads around that in this country is a mystery in many ways. But I think we're starting to make some progress, and hopefully we will continue, especially in the COVID environment, where we really need to think about this, because the illness goes so quickly and can necessitate immediate end of life decisions almost. You want to be prepared.
Gene?
And I'm just going to say, my comment would be, I would just ask everybody to take a few minutes and look at what you've done. If you've done something, make sure that it's still what you really want, and make sure that the appropriate people have it, so what you've asked for is going to happen. If you haven't done something, use this as the opportunity to look at the very simple forms that are on the Attorney General's website and fill out an advance directive, decide what you want to do. They've also got sample forms for other things that are related and helpful, like MOLST and the financial power of attorney. There's a lot of good information there, but this really is the time to think about this and have a discussion. Do it now when you're feeling good and you're healthy and you're in a good position. Don't create a situation where you're going to have your family fighting in an emergency room, where you're going to have a situation where you're not going to have happen what you want having happen to you. Take a few minutes and do the work and have a discussion with your physician about end of life. That's what they're there for. They're there not just to take care of acute illnesses, but to help plan your life, your health, and how you live your life with you, and help you answer complex questions.
Thank you to the three of you. I think the information you put forth was every bit as good as what I had hoped for and expected. Thank you very much.
Thank you.
Thanks, Ted.